My name is Wereski. I'm a clinical research fellow from the University of Edinburgh, and I'm going to present this afternoon some work that we've been doing on unstable angina in the era of high-sensitivity cardiac troponin. And whilst the slides are coming up, the talk will primarily focus on how the diagnosis is currently being applied, but then also what the future holds for this diagnosis as well. Push? I'm pushing. Not enough. Yeah. She's saying wait. Yeah, that's fine. Yeah. Probably could actually. So essentially, what do we mean by unstable angina? Well, unstable angina and its counterparts, acute ischemic death and acute myocardial infarction, were really defined back in 1992 in a paper by Valentin Fuster, who we know is editor-in-chief of JACC. And in that paper, he described the pathobiology of acute plaque rupture and described how these three conditions all share the same acute pathobiology. And together, he and colleagues termed them the acute coronary syndromes that we know nowadays. We are perfect. Okay. Thank you. Are we going?
If you want, you can go.
Yeah.
Okay. Try it now. Okay.
Perfect. Okay. So New England, Valentin Fuster, the acute coronary syndromes. And certainly over the past 30 years, we know that developments in biomarker technology, as well as non-invasive and invasive imaging, have changed the way that we treat and diagnose all forms of acute coronary syndrome. And certainly for myocardial infarction, the universal definition of myocardial infarction now mandates that clinical criteria and ECG criteria are combined with biomarkers to make that diagnosis. However, for unstable angina, such strict biomarker criteria don't currently apply, and this diagnosis can be applied in anyone who the clinicians feel has enough clinical suspicion to make that diagnosis and a troponin below the 99th centile. And what does that mean in practice? Well, it means that often a diagnosis is applied inconsistently around the world. And in a paper led by Professor Mills and Mueller, published in Heart, we've seen a threefold difference in the incidence of unstable angina between the Swiss and Scottish data sets. And actually in the United States as well, when legislation was introduced to reduce angiography for stable coronary disease, we've seen a 14-fold increase in unstable angina where reimbursement was still being provided. So these data suggest that unstable angina isn't always being applied in patients who could have unstable plaque. And it raises the question whether biomarker criteria that are used for myocardial infarction could also be used for unstable angina. And this leads me on to the two studies that I will present today. The first study is based from high stakes, and it's answering the question, how are we as clinicians currently applying the unstable angina diagnostic label? And then the second question, using the historic trial, how can we use a biomarker like cardiac troponin to help augment the clinical criteria and help identify the patients who are at highest risk of future adverse events who may benefit from further treatments or investigation? So the first question, how are we applying the unstable angina label? Well, the first question that we asked was, for patients who come in with suspected acute coronary syndrome, how many of them are receiving a diagnosis of any form of ACS? So we looked before and after the introduction of high-sensitivity cardiac troponin, and we can see here that the proportion of patients diagnosed with acute coronary syndrome of any form has increased since the introduction of high-sensitivity assays, which is what most of us would expect. But is this increase seen equally for both unstable angina and myocardial infarction? Well, if we split these same columns up into diagnosis, pink being myocardial infarction and blue being unstable angina, we can see indeed that myocardial infarction has increased since introduction of high sensitivity assays. However, for unstable angina, it's remained static. So this increase in total ACS has been driven by myocardial infarction. But who are these patients and what are their baseline characteristics and how has this changed before and after the introduction of high sensitivity assays? Well, as you would expect, patients who have a myocardial infarction diagnosed with a high sensitivity assay are less likely to have a range of cardiovascular risk factors such as previous myocardial infarction or heart failure, suggesting that high sensitivity assays are picking up a lower risk population with MI. For unstable angina, however, the same trend isn't seen, and these populations have actually remained quite static. But the more interesting question that we felt was, how do we compare MI patients to unstable angina patients? If we think back to Fuster's paper in '92, these are the same underlying pathobiology, so should have similar, if not the same, baseline risk factors and characteristics. So let's just pull these columns out and look at them together. So we can see that people diagnosed with unstable angina are twice as likely to have a history of coronary disease. They're 50% more likely to have a history of hyperlipidemia and diabetes or previous MI, and they're 3 times more likely to have a history of previous PCI. And remember, these are the same underlying pathologies that are occurring. So why is this, and has unstable angina become a diagnosis of risk factors rather than a diagnosis based on the patients that are felt to have unstable disease? And what can we do to try and augment that? Well, if we look at the clinical outcomes here in this cumulative incidence plot, we can see that patients with unstable angina in blue are far more similar to those who didn't have ACS in green, when we would expect them to have a similar incidence of events as those in red with myocardial infarction. But I say, what can we do to augment that? Well, any diagnostic tool that or any way we could use to risk stratify these patients must be able to identify patients with significant coronary disease, but also identify patients who have vulnerable coronary disease that we could use or we could augment with treatments. And of course, high sensitivity cardiac troponin is what I'm going to talk about today, with a number of studies now showing that cardiac troponin can predict, we're missing the first box, but essentially cardiac troponin can predict events, it can predict burden of coronary disease as well as unstable disease, and some emerging evidence to suggest it could help select patients for selective revascularization who have stable coronary disease. So a less than 5 threshold is used in clinical practice in the acute setting to rule out patients with myocardial infarction. So what happens if we apply this less than 5 threshold? Applying this to the patients with unstable angina, we can see here that yes, we do indeed see a separation in those with a clinical diagnosis of unstable angina and a troponin greater than 5 do separate those with a troponin less than 5. This is again shown here in this table, where those who have a troponin greater than 5 are 3 times more likely to have a primary outcome event of cardiac death or myocardial infarction, driven by both of these outcomes. But can we use less than 5 in practice? Probably not. It's a rule-out threshold used to free up time in busy emergency departments and direct the right care to patients who are suspected of myocardial infarction. And do we instead need to have a more bespoke threshold for unstable angina? And that leads us on to the second study that I'll present today. So in the historic trial, we looked at a total of 31,000 patients who did not have index myocardial infarction or myocardial injury. And we decided to look at the thresholds of peak and delta, or troponin change, that were associated with a doubling in your risk of having a myocardial infarction or cardiac death at 1 year. We then evaluated the performance of these thresholds in all patients, and then in patients that were combined with clinical criteria such as ischemic chest pain and ischemic changes on the ECG. So first, if we just look at peak troponin, we can see that area under the curve for predicting adverse events is excellent, as we would expect. But how do we turn it into a threshold? Well, we performed generalized additive models again, looking for, as I say, the threshold associated with a doubling in risk. And we can see here that for both males and females, the threshold of greater than 7 is associated with a doubling in risk. Then looking at delta change, we can again see that a threshold greater than 6 is associated with a doubling in risk. So we have these thresholds now, a peak troponin of greater than 7 or a change in serial testing of more than 6 that are associated with a doubling in your risk of having a major adverse cardiovascular event. But what does that mean for practice? Well, we've heard lots of, my slides appear to have moved a little bit, we've heard lots of conversations today and discussion about the importance of clinical criteria and clinical gestalt, and that is something that we wanted to recognise in this analysis as well, making sure to combine, just like we do with myocardial infarction, ischemic chest pain and ischemic ECG changes with objective biomarker criteria to identify the highest risk patients who would benefit from further assessment. So if we look at clinical criteria alone, so this is chest pain or ischemic ECGs, and we can see that having chest pain or an ischemic ECG, it doesn't really differentiate yourself from people who don't meet these criteria for the risk of having an adverse cardiovascular event. Now, certainly, if you have both ischemic ECG changes and chest pain, it does improve discrimination. So it is showing the importance of us as clinicians. I haven't managed to work my way out of a job, so we're fine. But it's really when we add in the biomarker criteria that we see the biggest improvement in discrimination. So these are patients with chest pain and ischemic ECG and who meet either a troponin greater than 7 peak or a delta change of 6. This trend was seen in logistic regression models. People who have chest pain and ischemic ECG, yes, your risk is doubled compared to those who don't meet that criteria. But when you combine that with the biomarker criteria, the odds increase more than twofold to 5.3. Importantly for clinicians in the emergency department, at the moment we don't know what to do with a lot of these patients who we think could have unstable angina. And actually just using the clinical criteria alone, we could identify about 16% of patients in the ED who could have unstable angina. By applying the biomarker criteria, there's a 10% absolute reduction in that, dropping to 5.1%. And this isn't about saying that patients who don't meet these criteria don't have unstable disease, but what it is about is identifying the highest risk patients where us as clinicians should be focusing our attention and investigations. And I'd just like to finish on this slide. These conditions, myocardial infarction and unstable angina, are thought to have the same underlying pathology. But for myocardial infarction, we've learned to embrace the tools that have developed over the past 30 years, biomarkers and imaging. However, for unstable angina, things have remained static, and surely time is now to embrace biomarkers into the definition. Thank you.
Thanks, Raya. First question, Professor Dissome.
Thank you, Ryan. I really enjoyed a lot. Your presentation is going to be of a big value in the emergency room, like you outlined at the end. I definitely like very much this difference cutoff criteria to starting to. I see a lot of room for application of artificial intelligence in that way. If I'm asking you, which are the criteria that you really would like to put in this algorithm? So you have already, let's say, a step forward, right?
Yeah.
Using this. But what you need, because there are still some overlapping, on what you present is still some overlapping. How can we make this effort? What do you really think is the next steps?
Yeah, so I think there's two parts to that. Obviously, it's important to include as many clinical and variables in your assessment of a patient as possible. But in one of the first slides I've shown, people who receive a diagnosis of unstable angina just based on risk factors alone, it doesn't actually identify the high-risk patients. So you're right, a more complex strategy is needed, and machine learning and artificial intelligence is certainly a way forward. However, at the moment, I think that would be too big of a jump to take, going from having no biomarkers to then a machine learning approach. But yeah, it's certainly something in the future where I think this pathway is going, blurring the lines between myocardial infarction and unstable angina and creating a continuum or a spectrum of risk.
More questions? I think it's important to underline that this cutoff proposed by you is on top of having
Yes.
clinical
Yeah.
symptoms compatible with angina.
Very much like myocardial infarction as well. You
Yeah,
can't, if you've got troponin above the 99th centile, that doesn't mean you've had a myocardial infarction. It has to be combined with clinical gestalt, ECG changes, and very much the same for unstable angina.
Nice proposal.
Thank you.
So thank you. Thank you, Ryan.